Okay, please continue. Could we switch now to New Delhi to Dr. Praveen Chandra? Welcome. You are online now.
Yeah. Hello.
Hello, Dr.
Hi.
Chandra.
Hello. Can you hear me?
Yes, go ahead.
Okay.
Loud
Okay.
and clear.
Okay. Absolutely. So now we are ready with the coronary case here, and along with me is Dr. Abhinav and Dr. Shantanu and the entire team here today. And let us see what we have in store for you. So the first slide, please. Yeah. So as you can see here that this is, a rather young patient, and this time he came with increasing angina, and he was diagnosed last year with, multiple blockages, but they were kind of, like medical therapy was also one of the options for them. So he continued medical therapy, but the angina was increasing. So we did a stress thallium this time, which was positive. So we said, okay, let us check the angio and then see if we can help you with some intervention. So let us have look at the angio. This is the LED which was fine. This is April 22 last year. And then you can see there was a big ramus. Go back, go back, go back, go back. Yeah. So there was a big ramus you can see, which was tight. You can't see this in this view. Go back last. Yeah. Yeah. Yes. Next slide. And the LED is fine. The ramus is the one which was the culprit most likely. And then there was a distal vessel also. This is a big OM, which the circ is terminating into. And the RCA is also having a disease at the PD, which is a diffuse disease. So now, definitely in these kind of situations, the first choice is that try to maintain it on medical therapy, because these are small vessels. These are like not, and the LED is normal. But certainly you can see that the entire inferolateral wall is getting affected, and that is why this patient's symptoms is not improving. So this today, we brought him to the cath lab. Next, please. Come to the fluoro image, please. Come to the fluoro. Fluoro, please. Yes. So this is today. So what you see here is that ramus, which was a big artery, is now completely occluded, and the distal circumflex is still there. It has increased a little bit more. And so now the next slide, please. Next image. So these are the pictures we have taken today. The LED is still fine, and the ramus is completely occluded. Next, please. Next. Yeah. So these are the few shots here, and then you can see the right artery, which is showing, the PD is showing a diffuse kind of disease, but certainly it's not a, vessel which is a standalone. We would just leave it like that many times. But in here, when we have taken this patient up for intervention because of increasing angina, not relenting to medical therapy, so we have started to do the intervention in this patient. So the first plan, of course, is to do the ramus. And as you can see here, okay.
Yeah. You want to do the complete revascularization, even in small size.
I mean, the thing is, if we are able to do that simply, we will do that. And first, of course, is to open this ramus, which is completely occluded. So we have taken
Dr. Chandra, this patient has known coronary vessel disease. How was his LDL cholesterol level by admission? Could you tell us?
Yes. So he was on full medical therapy for the last 1 year, more than a year, and statins were being given. He was also on ezetimibe, so everything was being tried in in the hospitals outside. And then finally, when nothing was working, then he finally landed up here.
Okay. Praveen, presence of multiple vessel disease, the decision is to be taken, the simple vessel to be dilated fast and stented fast. Simple vessel to be.
So in this kind of situation, yes, that is one of the things, whether to dilate this circumflex first, because generally, if we are treating a proximal vessel, also a distal lesion, we treat the distal lesion, because then if we have to do a stent or something, it will be difficult for us to go back into the, the main vessel. Like for example, here, if this ramus was not 100% occluded, I would have done the distal LCX first. But here what I have done is, since it is 100% occluded, I thought it is better to do this first, because this is the most important artery for him right now.
But we have a safe landing.
And then we have a safe landing zone, and also we have this thing in mind that most likely we will be able to do it without a stent, because these are not big vessels. My plan is to, as much as possible, finish them without putting stents like drug coated balloons. So this is my upfront plan. And we took a Fielder XT wire, and you can see that it went in not with too much difficulty, little maneuvering, that's all. And this wire is in, and we have done a 2 millimeter balloon dilatation. And now I have taken the IVUS here to see what size the vessel is, because sometimes these vessels are big, and on angiogram they look small because they are underfilled. So I'm going little inside, and you can see this is the. Can you see the IVUS image now?
We can. Can you make it, Praveen? This is Saurabh. Hello, by the way.
Hello, Saurabh. How are you?
So yeah, perfect. We wanted to see IVUS on a bigger screen.
Yeah. So you can. I'm just this is the position of the IVUS catheter. Okay.
So
Maybe we can
Praveen,
do a
talk to
quick
us
check.
on choice of imaging modality, on when do you reach out for IVUS versus OCT?
Yeah. So in this situation, typically when the vessels are occluded, they are 99% diseased. Then once we have done this initial dilatation, still the flow was not that great. So that is why we decided to use IVUS, because here it is not flow dependent. Okay. So here we are doing IVUS will give us a lot of information about the size of the vessel, how the plaque is, and from where to where we have to do the treatment. And do we need to do any additional modalities like, cutting balloon, shock waves, etc. So all this information will come in, and the size you can see, it is about 2.5. And I'm pulling back now slowly. So you can also look at the fluoro image. The artery is reasonable size. Okay. And here it is quite actually nice. Okay, check, where are we? Okay, this is the proximal segment. And you can see, this is very interesting, that the ostium of the vessel is not all that bad. Okay, so we will take a 2.25 cutting balloon and see how we can modify this plaque, because it is not very heavily calcified or something. And typically, in those cases where we are planning a DEB, because of the size of the vessel, because of the location of the lesion, it works quite well. So there may be some discussion about whether to use a cutting balloon or not, whether to use a DEB or a DES. So you can have some discussion. I'm taking a 2.25 Wolverine. Okay.
So let me ask the panel on what do they think of this strategy. So what do you think of this strategy up front, cutting balloon with a
If you ask me, I would definitely go with 2.5 and C balloon, and then would make final decision if some additional cutting balloon dilatation will be definitely needed or necessary. And then I agree with Dr. Chandra fully. I think we should try to
1, 2, 3,
not to
4,
stand this segment.
5,
Should
6, 7,
try
8.
to work here with drug-coated balloon. This will be my first choice.
Yeah.
So
I mean,
in
actually, you
vessels-
have to deploy the
Deflate.
of the cutting balloon very slowly, and at least duration of
Go up 1, 2,
full
3,
inflation
4,
only 15 seconds. At the
5,
atmospheric
6, 7,
14 to
8.
18, as you like.
10. So this is going up to 10 atmospheres. Deflate, please. Okay, we'll come up to the near the ostium. Okay, go up 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 12.
This is osteal lesion for this intermediate branch.
Deflate.
Would you suggest younger doctors should protect LAD main branch, or just because you in
Good opening.
case of troubles you have extremely experienced operator, you can manage left main dissection, whatever. But
Go
I
up
think
1,
for
2,
younger
3, 4,
doctors will be not bad to have
5, 6,
a
7,
floppy
8,
wire in LAD.
9, 10. Deflate. Okay, so here, typically if you have to look at the, the bifurcation, the ostium, and everything. And based on that, many times we have to protect, as you said rightly. But in this particular situation, I don't think it will be very necessary to do that. Go up 1, 2, 3, 4, 5, 6, 7, 8, 9, 10.
Okay, Dr. Chandra, please
Reflect.
continue lesion preparation, and then we will come back to you to see the IVUS. Yes, probably yes. We switch now to Dr. Chandra. Dr. Chandra, you are now again online. We see IVUS again.
Can you hear?
Yes, go
Okay.
ahead.
So show the previous that image. Go to that. After the cutting balloon and this thing. Okay, so what we did was, in front of you we did the cutting balloon, and then we did an IVUS to see if there is any significant lumen loss or any dissection or something. Go back, 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 go back. Oh, go back. Yeah. So we did the IVUS to figure out whether we have done enough as a vessel preparation or not. So we found on the IVUS that the vessel preparation was quite okay. And show the IVUS, please. Run it. Yeah. So you can see the IVUS images now. And we found that everything is okay. The lumen is quite reasonable. And so at this stage, we decided that, okay, this looks like, so these are the markers of this IVUS catheter. And you can see it is about 22 with the 2 markers and then the distal imaging point. So we took a 25 millimeter. We decided to take a 25 millimeter magic touch. This is a sirolimus eluting balloon, and it is 2.75 diameter because the vessel growed a little bit. So after this stage, we took a 2.75. Go next, please. And this is a 2.75. And here we dilated it at a pressure of about 5 atmospheres only, because here we have to just touch the vessel walls completely so that we deliver the drug. And we kept it for 2 minutes. So many people will say, okay, we generally keep it, it's recommended for 1 minute, but those patients who tolerate it, I give it for 2 minutes so that, whatever maximum delivery you can do. So this is 2 minutes inflation. Next, please. Yeah. And so we are checking if the balloon is well dilated. It is. And now this is soon after the, the deflation. You can see that, the ostium of the ramus looks good. The middle part is looking good. And there is no significant flow limiting dissection. And the vessel is looking fine. So at this stage, there is no need to put a stent here. And this gives us 2 advantages. The one, that this vessel, if it has a capability to grow, it will grow. The second is that it doesn't land up into either the ostium of the LAD or the circumflex, and doesn't create any future problems.
I think that's really good decision making, and I completely agree on this treatment strategy.
Next.
Yeah,
So
it's
now-
finally a huge vessel, right?
Yeah.
The long vessels.
So
Well,
you saw
often-
that we started with a small vessel, and now we have a 2.75 vessel,
Yes.
which is the ramus. So now we are taking and gone into the circumflex. And here, this is again the same cutting balloon. Although we would have taken a 2.5, but we have a 2.25 here already, which was used. So we will go with the same one and see if it crosses. Yeah, it has crossed. And I will check it a little bit where we are. Okay, perfect. So with this, we will go up 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 12. So at 12, what is the size of this balloon? 2.35. We can go up to 14. Go up to 14. 14, please. And that looks nice. Okay. So deflate. Okay. So we'll do one more inflation here, because sometimes, doing 2 repeated inflations is better than 1. Go up 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 12. Okay. Deflate. So for this also, our strategy is to see if we get a good dilatation. This looks quite nice.
Yes,
You
definitely.
see, there
I
is
think
no
the next
dissection.
step- The next
Yeah.
step will be to work here again with drug-coated balloon. probably
Yeah, I think so.
2.5.
Why not? Because this is a very nicely dilated vessel. There is no dissection, and we can just do a DB here. So we can take another drug-eluting balloon. Give me a 2.5, 2.5 into 50.
In this
15, please.
projection, we can also very nicely see the distal LAD problem. There's a tandem stenosis quite distally, but
Yeah.
probably you could also approach.
It's pretty
Yeah,
far
so the
out.
distal lady is very, very, so we will leave that. And this is a big vessel, this OM, because this circumflex was just finishing into this big OM. So that's why we are treating this. And hopefully with this balloon dilatation, give me a magic touch. We have a magic touch here, 2.515, again a sirolimus eluting balloon. And we have now used about 450 of these balloons in the last 2 years now, and our experience has been quite positive. And
Okay,
our
actually-
dominant strategy is to do a good vessel preparation all the time.
Yes, that's a
when we
crucial
are doing
point,
this.
and it was
Yeah.
really
Initially,
excellent.
people started, Praveen, initially started after cutting balloon, they also used the NC balloon, then followed by the drug coated. But nowadays,
Uh,
after the cutting balloon, rough area is there. If you deploy the particularly DS drug eluting balloon, so therefore drug delivery will be better way. That is very important.
yes, absolutely. Go up. 1, 2, 3, 4,
Okay.
5, 6.
Dr. Chandra
7, 8,
will
yeah.
go now again to, I think, Dr.
Yeah, so here you can see that this is the 2.515 DEB. We'll inflate it for about 2 minutes. So now you
Perfect.
can go to the
It looks like a bit
colleagues
too
in
small,
Hyderabad.
maybe, but we will see.
Yeah,
Okay, we
yeah.
go now back for a short moment to Dr. Rat to Hyderabad back. Dr. Chandra, you are back
yeah.
to show us
Okay,
the final
okay.
result.
So go back, please. Go back to the images. Go to the multiple screen. Yeah, go back.
Yeah.
Okay, come to this view. Okay, that one. Up, up. Go up, back. Yeah.
Okay, Dr.
Okay,
Chandra,
okay.
show
Yeah,
us
sure.
first circ.
So, okay, so next, please. So here, what we did was we showed you the ramus, and now we were doing the dilatation of the circumflex, which we did with a 2.25 at high pressures, so that the size of the balloon became about 2.7, 2.5 or so. And then after this dilatation, we did a 2.5 into 15. This was again a magic touch. As you can see, next slide, next please, next. So this again, we did a dilatation for about 2 minutes, and you can see the result looks quite awesome. No dissection, the flow is good, and all the branches are flowing, even the smaller ones.
Perfect.
So with this, we moved on. Next, please. Next, please. So now we're in the RCA, going into the PD. So this PD is quite a lengthy PD, looking very diffusely diseased. So again, the plan is to have a good dilatation of this PD, then see what we should do. But our dominant plan.
What was rational to go to the very small disease PDA at
Okay, I'll show you. This is not a very small PDA.
distal LAD.
Yeah, so this is not a very small PDA. I'll show you. This is show the IVUS of this PD. This PD is 2.5 millimeter vessel, and we have done initially a 2 millimeter dilatation. Next, please. Next. So this is a 2 millimeter dilatation initially, and next. The other reason why we went into this in the stress thallium, which was the nuclear scanning, the ischemia was in the inferolateral segment. Otherwise, sometimes we go for the LAD also, but this was one of the reasons, because it was all inferolateral territory.
So
Okay, next, please.
Targeted based on your imaging
Yeah,
studies.
yes. So everything is based on that. And then we did the dilatation, we did cutting balloon inflation, as you can see here. Next, please. And then we moved on to a 2.5 cutting balloon. So you see the vessel is growing gradually. And show the IVUS, please. IVUS.
We're still seeing the IVUS.
Okay, you're still seeing the IVUS. So remove the IVUS now. Now go to the fluoro image, please. Yes. So this is a 2.5 cutting balloon. Again, Wolverine. So for us, in these kind of situations, let me clarify. We have 3 cutting balloons here: the angiosculp, the Wolverine, and the Scoreflex. But we find that when we have to do these kind of dilatations, and we are predominantly thinking of a DEB, we want a Wolverine only, because the chance of a dissection is quite minimal, even if we go to high pressures. Next, please. Next. So go back. So we have done the dilatations, and now we will show you how it looks. We showed you already. So we'll take a DEB now, drug-eluting balloon, again, a 2.5, and this is a longish lesion. So we'll have to take at least a 35 or a 40. Yeah,
Yes,
give me a 40 millimeter.
I mean, it's
So you
already
see-
looking to be a sizable vessel.
This is 2.5 into 40.
Yes. So we are taking a 2.5. I mean, it is between 35 to 40. So I'll go with a 40, because even if it hangs into this RCA, it is okay, because
When
it
you use the
doesn't harm
cutting balloon,
anything.
do you cover the ostium of the
Yes.
PDA?
Yeah, absolutely. So the advantage of doing this kind of technique, especially when we have osteal lesions, is that there is no overhang of the stent, because there is no stent. And
Yeah.
these patients are small vessels. They are like 2.5 vessels, long lesions. I think this strategy is quite helpful. And if there is no occlusive dissection, if there is no flow limiting dissection, then we generally go with this. So
Yeah.
in contrast, if you go with a high pressure balloon inflation using a NC balloon, the chances for pre-dilatation, the chances of having a dissection is higher.
Definitely. So we
Yeah.
agree with you 100%. Dr.
this is
Chandra,
a-
we
yeah,
just
so,
let
yeah,
you.
this- Yeah, so look at this. This is a 40 millimeter balloon, which is absolutely right in size, 40 into 2.5. And I'm going to do the dilatation now, so you can carry on. Thank you.
Okay, perfect. We
Check, please.
Dr.
Okay.
Chandra, now you are probably absolutely ready with the right.
Okay, so show the fluoro image, please. Fluoro image. Okay, so here this is the 40 millimeter, again, the magic touch, which is a sirolimus eluting balloon. And we have gone up to low pressures only, because the vessel is just 2.5. So it is only 5 atmospheres. The balloon is fully dilated, expanded, and we kept it for about 1 minute 45 seconds. And next, please. So next. Yeah, and now this is the image after the dilatation, and we see that all the branches are fine. There is no problem, no major dissections here. And I think, this looks like a reasonably good result. And I don't think we need to do anything further. No stent implantation is required. So
I agree.
There's some recoil is there. I think needs.
I mean, this
Yeah,
much is absolutely,
another
this will start, healing on itself. But overall, it looks very good.
Yeah, excellent result.
And so this is what I wanted to demonstrate, that in lesions which are like in small vessels, long lesions, distal lesions, osteal lesions, all these situations, one of the strategies which we do these days is do a good atherectomy using either a shock wave. If it was calcified, I would have done a shock wave, followed by cutting balloon, and then followed by. So we have to get a stent-like result before we do a drug-eluting balloon. That is the key to success in these patients.
No, this is fantastic result, Praveen, and really, really good decision making for the audience. So thank you very much for
Thank you.
sharing.
Great job. Thank you so
Great
much.
job.
See you
Congratulations.
soon.
Thank you.
Thank you.
Bye-bye. Thanks.